I would never say that like the US is necessarily a better system to be training in. I think it is a different system to be training.
Even though you are humble, at the same time, you need to be confident or self-aware of your skills.
Become someone who will improve the field for the better. Like, do not fall into like the traditional toxic ways of surgery. Like, we as the younger generation have the opportunity to change this field for the better, which will only ever improve it for our patients.
You need to be a good leader.
Yeah.
You need to be a good decision maker. You need to have that resilience to become a surgeon.
Just the most amazing thing in the world to be able to like fix someone and do your best for them and to save their life. There's just like nothing else like it. Like, I just don't find anything else like operating at the end of the day. But that cannot be taken lightly. It comes with a lot of responsibility. And so you have to be ready to take that responsibility seriously.
Has this MBA helped you manage your personal finances as well?
You don't get as much personal finances, but it did make me realize that I need to manage them.
Hello, everyone. On behalf of our entire team, we would like to welcome you to a brand new podcast series, We Dissect. So, We Dissect is a podcast series by a team of medical students and medical graduates who are interested in exploring the depth and breadth of surgery in Nepal and on a global scale. By having an honest, unfiltered discussion with surgical leaders, surgical trainees in different surgical specialties and working in different surgical settings, we want to gain their insight, reflections, and learn from the experience they have had over the past surgical training of theirs. If you find value in our content, please stay connected and let us know your comments or feedbacks. Thank you. Hello everyone, welcome back to episode 2 of our podcast series We Dissect. Today we have a very special guest and indeed the first international guest to our series. She is Dr. Anusha Jayaram. She is a general surgery resident at Beth Israel Deaconess Medical Center and Harvard Medical School. She was born in Singapore, raised in Australia, and then she moved into US. And now she is in Nepal, currently doing her Fogarty Fellowship with University of Washington, and her research currently at Kirtipur Hospital is on burn surgery, and her interests include global surgery, surgical education, and advocacy. And for all the work she has done, she has received numerous accolades. 2 of them worth mentioning are Dr. Wasser Height Young Leader Award and Boston Congress of Public Health 40 Under 40 Award. So we are really excited and honored to have her in our series. And without any further ado, I would like to welcome her in our podcast series. Okay, namaste, Anusha.
Namaste, Rajwal. How are you?
I'm good. How are you?
I'm really good. I'm really excited to be here today and talking to you.
Yeah, so I would like to thank you on behalf of our entire team for accepting our invitation and joining us for this talk. I'm really excited. So, although it's late, I would like to welcome you to Nepal.
Thank you.
And welcome you to our second episode of our podcast series, We Dissect. So let's start with your journey to Nepal. So what made you come to Nepal?
Yeah, so let me give you a little bit of background on how this happened. My interest has been global surgery work for a very long time. And so right now in general surgery residency, everyone in my program does at least 2 years of mandatory research time. And I knew that for that research time, I would want to be abroad and learning about, how to engage with systems and improve them. And so I applied to a international fellowship that is affiliated with the U.S. National Institutes of Health called the Fogarty Fellowship. We have a Fogarty International Center within the NIH that supports a lot of the international work that's going on. And so as I was looking for mentors to work with for this particular fellowship, the reason I picked the mentor that I'm with, Dr. Barclay Stewart, who's a burn surgeon at the University of Washington, is because I saw how he had built this partnership with the surgeons here in Nepal, and it felt very equitable. It felt very centered on like practical research that really had the capacity to make an immediate difference here for the patients, and also building a lot of research capacity amongst like the local research assistants, the local surgeons, and really supporting their growth, as opposed to, the historical global health work can be very inequitable and very actually like academically beneficial only to the high income country partner. And so I wanted to really learn how to work outside of that and to build like a new paradigm in global health. And so, really very much wanted to work with that partnership and learn from them and how they had built everything that they had built in like the last 5-6 years here in Nepal. And so Along with that, though, for myself, like I'm from Singapore originally, and my background is Indian, and so there's like a certain cultural connection I think all South Asians have, and so many of my colleagues in surgery in the U.S. tend to work in different countries in Africa. I think less so in Asia, but for me, just having been from Asia, understanding the cultural context, it also I think made sense to work in a place where I had some familiarity with it, and just understanding like the cultural differences and like what creates change and how people live. And so both of those things really ended up contributing to why I wanted to come to Nepal in particular.
And I know that you are quite active in global surgery and you have done a lot of works in it. And so, like you mentioned, there was already established partnership with the Kirtipur hospital, and that made it quite easier for you to come. And because if I recall it correctly, there had been previous fellows as well. So how did that... you must have gone through the works of previous fellows, and when you had to decide the actual project you want to do in Nepal, how did you plan that ahead? In which year did you start planning it?
Yeah. Thinking about what has happened before, I think, is really critical. And especially as a trainee, it's very hard to build something from scratch, because you don't know everybody in the network that you need to know. You might be unfamiliar with the place. This might be the first time you're doing something. Everyone comes in with a different background. And so, especially for trainees, I always say, I think it's important to join a partnership that's already been established, because a lot of that groundwork has hopefully been done, and it doesn't give you such a huge startup kind of curve in whatever it is that you're trying to work on. And so being able to step into a partnership that had already been starting and conducting a clinical trial is like a really nice foundation to work on. And so in building up the next project, what I really did was like talk with the local surgeons and also the previous fellows that had been there about what are the things that people here are talking about that would be useful and needed? Like, what is the gap that is there and how do we help close it? And so a lot about what I had heard was rehabilitation. So with burns, it's not just about the acute surgery. Of course, we can excise and skin graft somebody, but after that, they have a lifetime of rehabilitation ahead of them. This is a very traumatic injury, both like physically and emotionally. And there's this whole thing within burn surgery about how people lose their concept of the future that they had envisioned for themselves when they get burned. So it's not just like, oh, I broke a bone, I'll be, 2 months out. It's really this like sense of self that gets lost. And so something that has been very popular in the US and many other high-income countries is this idea of peer support. So patients who've had a particular condition supporting other patients with that same kind of condition. And it's been very successful with burn injury patients. And so peer support and peer support groups became one of the topics that the local surgeons and the local community here I was hearing about felt like there was a huge need for that. And I actually, a little bit by luck, had done a previous scoping review on peer support in the community setting in my previous global surgery fellowship. And so I'd already had actually quite a bit of reading of all of the literature as I did that scoping review. And so I was like, this is actually something that's really cool. And I also come from a humanities background in terms of my undergraduate degree. And I always have loved thinking about how people relate to each other and how then they relate to the world. So all of these things that actually I was naturally interested in, and there was a gap to meet with like a particular intervention came together. And so that's how the peer support group intervention program research project came together for me this year. For Fogarty, you have to submit your application in September of the academic year prior to. So that's at about 9 months ahead of time. And so we started talking about this project about 10, 11 months ahead of time to, build out the grant and application.
Yeah, I like the way you try to combine two different aspects, the science as in surgery and the humanities aspect, that is storytelling and the support mechanism. So, so I would like to draw now into the actual fellowship you are doing. So as you had planned when you were in US and when you came to Nepal actually, so what were the difference here in the ground, or how different maybe you had some plans to go in this and this direction, and once you came here, right, it starts from the IRB approval from NHRC, and it's a lot of things there, and a lot of changes maybe or have been made. So can you elaborate more on that? How much you had to modify?
So overall, actually, I think we stayed true to the core of what we wanted to do. I think that when I first came here, what we were trying to figure out was the appropriate groups to start out with. And this goes for research, or if anybody is trying to start any kind of intervention in a new setting or a program in a new setting. And at the same time I did medical school, I also did my master's in business. And I think that has given me a lot of insight actually into like managing this kind of like introducing a new concept, managing the change of it, managing the sustainability, the funding, the scaling of it, which is why I did the MBA. I am like a public health like advocate at heart, but I knew that like the business world has like many different frameworks for making a project successful. And I feel like in medicine, we don't always think about those frameworks. I think that like good intent is sufficient. And the reality is it's not, because society is more complicated than that. And so we have to have some kind of framework in mind when it comes to starting something new. And the peer support groups, while we have a lot of research, right, in the high-income countries that it's very successful, coming into Nepal, it's a new environment. I know that people come in with different levels of health literacy and also a very different understanding of mental health, right? In South Asia, I know that this is something that is an up-and-coming topic. And so when we started thinking about what would make our project successful, we thought about what groups would probably start talking to each other the easiest, right? This is a peer support group in the hospital was going to be a group of people coming together and opening up about something that was very difficult, right? And so first group we thought about was parents, actually, of children who'd had a burn injury. Because one, this group is not the group that had the injury itself, but they're the next close thing to that child. And many parents have a drive to want to figure out how they can help their child. And that, I think, overcomes this barrier of talking to people. And I think when they talk to other parents, there's this like, oh, you know what I'm going through connection that they have that's just internal to how they relate to each other. So we thought that group would be quite successful. And then the other group we thought would be successful actually was a women's only group. So I talked with many different people, and one of the people that was key to this is at Kirtipur Hospital, there's one professional mental health counselor there for the burn division. And he has, I think a lot of good insight into like the intersection of mental health, surgery, and then the culture of Nepal. And we thought separating the genders would also be important at the first stage, because we thought, would a 22-year-old young woman feel comfortable talking about her burn injury in the same room as perhaps a 55-year-old married man? There's certain, cultural barriers that can exist in people fully being themselves. And these groups, that's what we want people to do. And so this is where we're talking about these structural changes, these cultural understandings that allow a group to be successful. And so that's how we determined those were the two groups that we were going to start with. And then also what I discovered was most of the candidates for the position of the peer facilitator were all women. They were the ones who were coming to a lot of the programs for burn survivors, doing some prevention advocacy work. And so, it's one of those moments where I was, okay, I'd like to have a men's group as well. I do hope this intervention eventually gets out to them. But right now, I can't find a appropriate candidate for the peer facilitator position, and it didn't feel appropriate to have a woman lead the men's group. So these are kind of the limitations that you start seeing of like, you can't just insert anything into the program. You have to be thoughtful about how it's run to make sure that the group is as successful as it can be. And if there is any reason that we run into any barriers or failures, it's not because the intervention itself is poor, but it's all the circumstances around it. So those were kind of the biggest changes coming in, was like being very selective about our groups, and then like timing of the groups, changing it to afternoon after nursing shifts, understanding how the flow of the hospital went, and then also doing a lot of education for like the nurses, the physicians, everyone, because no one, even in the clinical setting, had ever heard about this, right? So you really realize, oh, I've got to do a lot of training of everyone else. Because if they don't know what it is, how can they tell the patients you should go and, check out this intervention? And then, of course, regulatory-wise, there's many different ethics reviews you have to go through when you're doing cross-country research. So we have to get 2 different IRB approvals in Nepal, our institutional IRB, and then the National Health Research Council, and then also the University of Washington approval. And then we also, in Nepal specifically, have to get approval from there's the Social Development Council.
Social Welfare Council.
Social Welfare Council, yes. And they approve all of the NGO partnerships and money coming in from overseas. And so thankfully, University of Washington already has an MOU that's been approved by the Social Welfare Council.
Okay.
But we still have to amend it because there's a new program that now is being implemented. And so then that took a while because there was some, I heard like ongoing leadership issues within their division. And so nothing was being approved for a few weeks.
Okay.
And so these are things that, you just don't anticipate coming up when you're planning your project timeline, but you have to be flexible with it because the ultimate goal is to help the patients.
And how long is your fellowship, and how frequently do you keep in touch with your mentors, both the international and the national ones?
The formal fellowship time is 1 year. It's the academic year, so beginning of July to end of June. Our setup is that we actually have weekly meetings with the whole team. Okay. So Tuesday nights is when we have our meeting with Dr. Stewart, who's our US-based PI, and then Dr. Kiran Akarmi and Dr. Shankar Rai, who are our two senior surgeons here in Nepal. And then all our research assistants also join this meeting. And if we have any kind of like medical students or trainees who are actively working on projects with us, I also encourage them to try and attend those meetings to be a part of the team and to present their work. It's good practice for them. And so, but then of course I see our Nepal PIs usually almost every day here. So there's a lot of things that, we talk about kind of just when I run into them and I talk to them. And that's actually been an interesting thing because in the US, I feel like a lot of communication happens over email or over a planned meeting. But here in Nepal, I found like communication-wise, a lot of people just like, they just call people and they talk to them.
It's sporadic, yeah.
Exactly. Or they just walk into their office and they talk to them. There's a lot of face-to-face contact. And that's been, lovely because I actually really love human interaction. But it's even these like simple little things where if I was in a different country, I can't just walk into someone's office somewhere else. And so it really helps facilitate a lot of the work is just seeing people, in the same office, in the same OT, wherever it is that you are.
And since you just touched on the sustainability aspect, I would like to ask more on how do you see this program sustaining after a fellowship?
So a couple of things I think that I have learned, and this actually fits into a bigger piece of the project. So of course, we're measuring outcomes clinically for these patients across different domains like sleep, pain, anxiety, depression, all of that. But the other half of the project is actually an implementation science analysis of everything so that we can figure out how to make this project sustainable in the long run and also hopefully expand its outreach to patients in the outpatient setting and also in rural Nepal. And part of it is because Kirtipur Hospital is, now the National Burn Center for Nepal, there's a lot of like advocacy and public health experts also coming in. There's a lot of NGOs also that are working with them for all sorts of different initiatives, either prevention-wise or training-wise. And so part of it is I know that those groups have interest in being able to carry out this type of program. And so I think our first step is to build up this body of evidence that says this is a successful project here, and then some like standard operating procedures on like how we made it successful here so that we can then give it to another group to be able to like take on and expand in different ways. So the hope is that once we are done with our data collection, we can show that this is a beneficial project for the patients, that we'll also be able to find local funders for it, because I think ultimately sustainability is about people in and of the community taking ownership of it and running it both from like an administrative standpoint, but a financial standpoint, and being able to, really put their own perspective into it. So I suspect that what will end up happening is there's already different like public health advocates and group leaders that are somewhat aware of this project, and that it'll end up kind of being done in partnership both with the group at Kirtipur Hospital and then one of these other groups that can take it out into the outside of Kirtipur Hospital setting.
Yeah. Since you said like Kirtipur Hospital has a lot of programs in burn and even community health workers, I think you must have heard about them. We have a huge amount of community health workers. My few projects are also based on them. So even for me, I had heard about peer support group faintly. And when I talked with you, I started exploring more on it. Definitely, we can utilize those community health workers even for the sustainability of this kind of projects. So I think we can talk about this on and on, but I would like to go on a big picture view and ask your experience in global surgery. So what was the first time you were introduced to this term, and what has your experience been so far?
I think the first time I was introduced to the term global surgery specifically was in the first year of my medical school. in the US, we have a lot of like student clubs and organizations for, anything you could be interested in. And I was in the club fair and I came across one table that was labeled the Global Surgery Student Alliance. And I'd never heard about this group before. And I was like, I'm interested in global health work, and I think I want to do surgery. This sounds like an intersection of these interests that I didn't know existed. And so I got involved with them and then learned more about this field of global surgery, which, honestly is really just global health with a surgical spin on it. I think we need obviously comprehensive healthcare systems. But it was GSSA that actually first introduced me to all of this work, and I got to meet other students who were interested in this. And also they had like an annual conference that we were able to, go to, attend, hear from faculty speakers. And it was really that network that brought me into global surgery.
So which year was this? Your first year of medical school?
Yes, this was 2017.
2017.
So it's a while back now.
For me, it was just opposite. I was introduced to this term in final year of my medical school. So it was around 2023. And so I started with the Lancet Commission of Global Surgery, the landmark paper. And I know you have been involved in a lot of alliances, like even GSSA as a research associated in PGSSC. So what were the projects you were involved in those things, and how have they shaped your interest in this date?
Yeah. Also, I just want to comment one thing that you said, that you're like, I only heard this term global surgery at the end of medical school. Because I think the reality is like this work is just surgical work, right? For people located in most of the world. And I always think about these issues around like equity and like what caused global health to become the field that it is. And it's that a lot of it has been shaped by the high income country perspective, right? And of course, it's global health if you're in a high-income country and have to go to a low-income country to do work. But if you are the majority of the world, right, that is existing in a low-income country, it's just every day for you. And so part of it I also just think about is like breaking that barrier down of like, for one person, it's a very academic thing, and for somebody else, it's their lived experience, and really moving towards this idea of like, this is somebody's lived experience day in, day out. And that leads to a lot of the work that I've done in global health, global surgery, and the research I've done, because that has really shaped this idea of like, this is just appropriate healthcare for everybody everywhere in the world. And so with GSSA, a lot of the work that I did was with global surgery education and like developing curricula for students. And a lot of that really was centered around this idea of like health equity and thinking about sustainable programs, whether it's research, education, advocacy, whatever that is like being able to engage in work that is centered around the values and needs of the people you're actually trying to help, as opposed to having any kind of outside professional come in and like, impose their belief on it. So we built up we had like webinars, toolkits, and even sometimes just like discussion groups that we would hold virtually, because everyone in the US is like very spread out, so virtual ended up being the best option that we were doing before COVID happened. So when COVID happened, actually everyone was like, this is a great model. And so building up a lot of those toolkits to help shape how students and trainees are engaging in it, engaging in global surgery work and giving them direction. And then also measuring students' understanding of what is global surgery, what does it mean to them, really finding a lot of people still have the perception they have to be a medicine doctor, like infectious diseases, to be in global health. But seeing that trend slowly change to people seeing like, you can also do global health with surgery, because otherwise how are people going to get surgical care? So that was a lot of the work with GSSA in terms of research. I also did help with some advocacy campaigns for USAID when it was a functional institution, and trying to get surgical specific funding for them, and a lot of grassroots work in the US of having the US students contact their Congress people and senators to support legislation for that. So that's like work that we can do in our own high income country settings, right? Is like making sure that we say, hey, government, like we want funding and resources to be supporting global health work. And so we did a lot of like letter writing and contacting people and advocacy work as well, and teaching students how to do that so that, they would go out to their elected officials and like talk about this issue on like a larger level. With the program in global surgery and social change, I took a an entire year out of medical school to do a research fellowship with them as a research associate. That was changed by COVID because it was the year of 2020 to 2021. So also all our work ended up being very virtual, but it did teach me a lot of lessons about the fact that you don't always have to be in the country to be doing some of this work, and that you can actually empower the local teams to be doing a lot of this work and training them to do so. On the flip side of that, this year has also taught me about really understanding a community that you're trying to help. And so there has to be some balance there with, I think, the virtual and in-person work. But with PGSSC, the mentors that I worked with did a lot of work around availability of blood products for patients. And so finding out new innovations and systems to improve the access of blood with like cold management systems or blood substitutes. Or one of the concepts that we talked about a lot was a walking blood bank, which is where you actually have a community of people who've been like pre-screened and pre-tested who don't donate blood until you actually need the blood. So then you don't need a fridge because, the person's keeping it warm and functional by themselves. But sustainable ways to essentially be able to contribute blood to surgical cases. And then with PGSSC, a lot of their technical expertise is around national surgical planning. And so that is helping governments or ministries of health come up with a plan on how they're going to expand their surgical care, anesthesia care to the levels that they need it to be on kind of like an entire structural basis. And this is actually something that kind of came full circle because when I started at PGSSC, I was supposed to help with the NSOAP in Nepal. And then COVID hit. And of course, that got, there were many other priorities that came into play. And then this year, I had reached out back to PGSSC because it was my research time to get involved in some advocacy work. And they said, actually, we're going to be starting the Nepal National Surgical Planning up again. And I'm like, isn't that funny? I am going to be in Nepal for this whole year. And so something about the universe brought all of that together. And now I'm actually helping with a project that I was supposed to be helping with then. But we, at that time during COVID, did a lot of virtual panels and virtual webinars and education trainings for mostly governments around the world on like how to improve access to surgical care within their own communities. And then also still a lot of like equity work around like developing sustainable partnerships between high-income countries, low-income countries. They really developing out the idea of like South-South exchanges and encouraging partners to be there for each other and not necessarily needing even a high-income country partner. So yeah, between those two fellowships, those were kind of like the major issues that I was working on.
Yeah, I am particularly intrigued by the way you said when there are some issues to be raised, you just advocate for it and you go to your governors and the public policy makers. At least from my perspective, till now, even if we raise the issue to the people who are in the decision-making position, it's quite difficult to make ourselves heard. So based on your experience, if someone, maybe with current government, the scenario can change and the election is out on every news right now. But if someone like me or if someone who is truly clinical and who is working in the forefront, but also wants to have some insights or feedbacks on these policy aspects, what could be a good point to start with?
So I think the big thing is similar to research of getting involved with a group that's already has established research, I think is getting involved with a group that already has established advocacy ties. So in the US, the example I can give is the American College of Surgeons, which is our largest professional surgical organization, has actually a very large advocacy arm. And what they try and do is make like events and projects that then physicians, trainees even can contribute to in kind of like a one-day format or like, in like kind of a short-term format because they understand that people are very busy clinically. So at the state level, ACS has state level leadership and groups, and they'll always have like what they call a day on like the Hill. What that means is like they go to the state legislature that day and they meet with all the representatives. They talk about their issues, and there's like an administrative body that's already planning that. And then what they do is they ask for surgical volunteers, like surgical clinicians to come and then be the representatives, and they help train them in like, oh, these are the things that we're talking about this year. These are the most pertinent issues we've identified. But you're the expert. You can give us your lived experience about these issues, right? Like let's say it's reductions in government funding for public insurance in the US, right? It is the physicians who can ultimately say, yes, I had this patient, this impacted them because they couldn't get their surgery on time and that led to a worse complication, right? That human story that the surgeon can give is very valuable. But there is a group of policy experts that are able to then shape when they go to talk to representatives, maybe before like legislation is getting voted on or before budgets are being approved for that year, as opposed to just a random time in the year. They can organize like all the appointments to be made so that the physicians just have to show up and they know that, there'll be somebody that's there waiting to talk to them. So that's where like kind of this partnership comes in of like having people who understand the advocacy cycle, who help organize, and then the physicians who are like, the frontline advocates for it. And I think that's a nice model so that each surgeon, physician, or, nurses even, like they don't have to figure out the entire system for themselves. And what you really call this is like collective advocacy, right? Groups coming together to advocate as opposed to it just being like one person at a time, because that group will always have a stronger voice together. And this is a similar thing you can see with student and trainee organizations too, and something that we did with GSSA, especially when we were trying to get more money for USAID, is we, for example, came up with a letter template that students and trainees could use to send to their elected officials. So they didn't have to like spend the time figuring out all the details themselves, right? We like reduced the barrier to be able to talk to somebody. And it's easy to either send in a letter or an email, or a lot of these elected officials have a contact page on their website. And so it's an easy copy and paste. But, if they want to change any of the language, of course, they're free to do so. But most of the information is already in there. And so those are ways that we can like kind of collectively help each other get involved in the advocacy arena without everyone having to become an elected official themselves,
Yeah. And since you have background of both anthropology and business administration as well, so I think these two aspects also factor in heavily when it's about decision making, not just the technical aspect. So if someone, for example, based on your current example, suppose if you find out that peer advocacy for or peer support for burn rehabilitation is an effective measure. So if you have to add the ingredients of a business as well as the sociology as well, so how do you incorporate those elements as well?
Yeah, and I think it's really important to be thinking about these things holistically like that. So from the business element, I think people who want to fund something more and more are wanting to see results. And I understand that because like they want to know that what they're giving money or their resources to is going to actually have an impact. And this comes back again to like, I think for a long time in our field, we've just thought that good intention is enough. And it's not, because sometimes you can have something that feels nice but doesn't actually improve anyone's quality of life or improve the patient. And so when you're building a project, being able to build in benchmarks or indicators of success that you can then measure is important. So this could either be outcomes, like saying like, okay, we know that we're going to reduce mortality by this amount, or, for the peer support groups, that's why we survey people on a longitudinal basis to hopefully what we'll end up seeing is like anxiety reduces over time, perception of pain reduces over time. And then this is also then why we do these qualitative interviews of people to get their stories and hear about how being a part of this intervention allowed me to reintegrate back into life. Like people want to hear things like I was able to go back to work, or was able to go back to taking care of my family, or was able to go back to school, or whatever it is that's important to that patient that they were doing before that then they were not able to do after this injury. And so when you can collate all that data, you can demonstrate both the humanity side of like, look, this person is able to go back to school, which allowed them to get the job of their dreams and go back and contribute to their community. You can also quantify that data and demonstrate things like disability adjusted life years, right? Or cost effectiveness research that demonstrate that by investing X amount of money into this intervention, you actually save a larger amount of money over the lifespan of this patient. People like to see data like that as well. Or they show that because you invested this amount of money, you actually saved this amount of money on a systemic level, because then people don't need further operations, they don't need further hospitalizations. They also start generating money for the economy by being able to, go back to work or contribute in whatever way it is. So being able to create these quantifiable aspects of the research will help policymakers, investors, make a decision about whether or not they want to give resources to your work. But I fully believe that we always have to center the patient, and that's where the stories of everyone comes in as well. And so we don't just show that, okay, we're going to save, 1 lakh rupees. We're also showing that this person finds more joy in their life after they're able to go back to work, go back to taking care of their kids, whatever it is that's important to them. And both things, I think, always need to be present when you're thinking about building these interventions, because there are also going to be some people who want to give money because they hear these stories and they're like, wow, that's such a huge impact. That's awesome. And that's a lot of where the grassroots funding comes in. And research has shown that being able to see people's stories really gets to people who give $20. But if 1,000 people give $20, that makes a much bigger impact. So you want to think about all of these different stakeholders, essentially, and the information that will get them on board with what you were trying to do. And for some people, that's numbers. For some people, that's stories. Some people, it's somewhere in the middle.
So yeah, at least based on my understanding, when I look back, so it's almost a decade from the Lancet Commission paper, and I think what has happened in the previous decade is we have done a lot of groundworks regarding what kind of surgery is needed, whether surgery is cost effective or not, and it is cost effective, and how much life is it preventing in terms of dialysis and all those things. But what I feel, it's my personal opinion, is that this literature is among the people who are quite interested in global surgery. But the people who are making these decisions, they find it too technical to understand these things like cost effectiveness and dialysis and all those things. So if someone, or if there was to be a plan for the coming decade in terms of global surgery, I think that would be the storytelling, how we change the narrative and how we can bring this story out to the people, because people understand things like tuberculosis, malaria, and AIDS, and they are ready to give them funding. But when we have to talk a bit about surgery, the narrative is changing, but not at a pace we want. So what different things can we do as a technical persons or medical students who are going to be involved in global surgery and who want to impact these things to the policymakers?
I think that, you're talking about how a lot of this research really has been kind of siloed in high-income countries, right? That's who has access to the journals where they can read about this, right? When you're behind a paywall, how is somebody supposed to read this journal article? And so what I really think needs to happen is it has to be the stakeholders from the low and middle income countries that have to take leadership in this. And I know that's hard to ask because there's already limited resources. There's so much clinical burden. But something that I always respect is I will never fully understand the experience of being the frontline surgical provider in a lower middle income country for my entire career, right? I, at the end of the day, will leave to go back to my residency in Boston. And even if I will choose to come back, I know that, but those are finite blocks, right? So I will never know the full pressure of all of this going on. And you're talking about, the stories of malaria, AIDS, tuberculosis, which are important stories as well. We don't want people dying from that either. But there's a reason that those stories became the prevalent story arch, right, in global health. And that's not because it was low and middle income country leaders deciding that. It was ultimately foundations that had a lot of money and people in high income countries who decided that. And if you really take it back over 100 years, a lot of people wanted to overcome these infectious diseases, to have improved labor populations, to extract resources from these LMICs that were run by multinational companies.
I never thought in that way.
There is there are several really good global health history books. One of them is literally called The History of Global Health, and I should have looked up the author before this podcast, but I'll get it to you afterwards. You can put it in the footnotes. And they talk about these histories of people invested in healthcare that would allow local labor populations to be healthy so that they could continue like mining or like building dams or like, the Panama Canal, right? Like somebody built that. It was not high-income country workers. It was low-income country workers who came in and did the labor. And when disease affected them, that's when they were like, oh, we need to fix this so that we have a healthy workforce. And those are the roots of global health. And so we have to recognize who has driven that story and change it back to like, what is the actual global burden of disease? And we know with surgical disease, that's almost a third of global disease burden, right? We know so many women die in childbirth from like peripartum hemorrhage, all of these different things that are not being addressed. And so I think a lot of it is that the story needs to be changed, and it needs to come from the people who are truly living it day in, day out. And I think of myself as like an adjunct, like I'm here to help and support, but ultimately like, I'm not here to insert my opinion as like the primary opinion or primary experience. I'm someone who just deeply cares about improving inequity in the world and helping as many people as I can. And a lot of the time that means I take a step back and just be quiet.
Yeah. Because even with my research experience with you, I felt that you are not here to do all the, hard jobs or take the credit of the work, but you are here to empower us. And it's really inspiring for us. So now let's switch the gear and go back into the training, because we are clinicians at the end of the day. So let's start from your undergrads and then move into your medical school and residency.
Yeah. So my undergraduate was very much impacted by this book that I read that I think many people in global health, global surgery have read, called Mountains Beyond Mountains, about Paul Farmer.
I've heard of him, but I've never read the book.
Yes. And so he was an infectious diseases physician, trained at Harvard, and really kind of like built up a lot of like academic global health infrastructure in the US, and was the initial founder of Partners in Health, which is also one of like the biggest like global health organizations in the US. And he was an anthropology major when he was an undergraduate. And he was someone who always talked about human stories and relating to people. And so this was a biography of him written by Tracy Kidder. And I read that in grade 10. And I was like, this is what I want to do with my life. Like it was like a life-defining moment. And so I was an anthropology major in undergrad. I was pre-med at the same time. I did all my pre-med courses, but I really valued the humanities exposure that I got, the writing that I learned especially, which I feel like people in medicine don't like to write a lot, but I don't mind writing at all. And so then after undergraduate, what I actually did was I did 2 years of research work. So in the US, I kind of applying to medical school is changing. It's becoming more competitive. So a lot of people take some time off between undergraduate and medical school. So I did 2 years of surgical research actually at Mount Sinai in New York. And that was where I was like exposed to surgery. And I got to shadow in the OR because we were collecting data for different research projects. And at first I was like, oh no, surgeons are kind of mean. And then I actually got exposed to this wonderful group of surgeons who were so nice and who still are so nice. And I was like, oh, actually, I think surgery is changing. And this is really interesting and cool. And this group of people are people that I think I would want to work with in the future. And so I kind of went into medical school thinking about general surgery off the bat. I remember telling myself, like, I'm going to be open to everything else. If I find something else I love, I don't want to be like anchored to the idea of surgery. But I was pretty sure I wanted to be a surgeon. And then applying to medical school, I was also thinking about this dual degree experience of, initially I was thinking of getting a master's in public health to, gain a lot of these public health skills. But then it was from my work experience that I realized that even though my ethics are that everyone deserves healthcare free of charge, no questions asked, that a lot of the decision making was built around business models and economic models in the US. And so to be able to actually create systems level change, I pivoted to doing a master's in business instead, to understand that world and to be able to then speak the same language as a lot of the people that I knew I would need to convince to give me money to make the change that I wanted to see. And so medical school, I kind of got involved in GSSA, as I talked about before, and also clinical surgical research off the bat, and kind of focus mostly on doing surgical things the whole time. When I was in my clinical year, OB/GYN was probably the only other specialty that I was like, I think I might be interested in this. But I think also for the fact that it would be a surgical specialty.
Mm-hmm.
But ultimately, I thought that like I was more interested in the pathology that came along with general surgery. So I went with that. And then I took the research year to really solidify skills in research and global health, which I was very appreciative of being able to take that time. And then when I was looking to residency, I knew I wanted to do an academic residency. And so in the US, residency is very, very diverse in the types of programs you can get. And so for surgery too, you kind of have the spectrum of like community programs where you have a lot of high volume, you're really focused on becoming a really good surgeon for bread and butter things in general surgery, to highly academic programs where it is mandatory that everyone take time for research. I knew I was very much leaning towards academic time because I wanted to take that time to do global health work, because I knew that as a clinical resident, I just wasn't going to be able to do both. Like, it's impossible to work those amount of hours and then do research on the side. Like, you do maybe like one paper a year that you like, chip away at. But so I looked to almost exclusively 7-year general surgery programs that would give me the 2 years of research, and especially looked at programs that were supportive of people doing global health research, because as we've been talking about, that change is happening slowly about people, I think, like valuing global health as a academic discipline and not just like a hobby. And so then I looked to different programs, and I ended up at Beth Israel, which was also in Boston. I went to Tufts for medical school, which was in Boston, and so then stayed on in Boston at Beth Israel. So now I've done 3 years of my clinical already, and I'm on my first year of research.
Yeah. Can you elaborate how is the MD MBA program different from the MD program, and how has it shaped your understanding in this business model behind the medicine or surgery?
Yeah. So MD MBA programs are kind of different depending on which school you do it at, and not every school offers it.
Okay.
The Tufts program was really, really cool, and actually one of the first programs in the country. And it is in partnership with Brandeis University and their school, their Heller School for Social Policy, which made it a really cool MBA, that it wasn't like something that you were just learning about venture capital. It was like one where like, it was a lot of like social justice, healthcare management really involved in it. So, you'd learn all these like economic principles, but then all the projects that we would do would really directly relate to something in the hospital or healthcare systems. And so I really appreciated that like application of these like business principles to the healthcare world in some way, shape, or form, whether it was like economically, tech, process improvement, whatever it is. And so for us, we had a lovely, actually 4-year schedule. So medical school in the US is 4 years long. And we are, I think this was one of the only 2 or 3 programs in the country at the time where it was also then only 4 years for the a master's in business added in. So we started like a summer early to 4 business school courses. And then during our first and second year, people have some spare time for clinical electives. During that time, we had our business school classes. Same thing with our 3rd year and our 4th year. And
how big was this group of MD MBA?
My group, I think, was on the bigger side. We were 11 people.
Okay.
So usually it varied between like 6 to 15 people each year. And so, yeah, we all kind of went to class together and like worked together a lot. So Tufts had a really nice, I think, partnership with it. A lot of other schools in the US, though, they make you take a separate year. So you'll take a 5th year, usually between your 3rd and 4th year of medical school, to do the bulk of the course load for it. So ours is a little bit different. And that's what also allowed me to put my research year also in with the MBA at the same time. And then you asked about how it's shaped kind of like how I view things. I think it's very much made me think about the practical and logistical aspects of delivering healthcare. I don't just think like, oh, we have this new intervention, we're going to give it to patients. I am also thinking about like, how are patients coming to access us at the hospital? Like, how are they getting insurance? How are they having financial security for all of this? What are the systems that are facilitating good care for them, or barriers that are preventing them from getting good care? And I think that the MBA taught me a lot about like changing that in like a practical way. And actually, I applied a lot of that work while in medical school to my leadership with GSSA. So eventually I became one of the national co-chairs for GSSA, and we're constantly thinking of like, how do we start new projects and then get them to as many students as possible, right? And that's where my like MBA brain came in of like, how do you create a marketing plan? Like, who do we market this to? Like what platform is going to be the best to disseminate this work? How do we make it most accessible? And so like automatically with thinking about these projects, I think about how do you make it actually work? And then I think with my research and like advocacy work, all of the same things kind of came in. Like immediately when I think about anything new, I'm like, okay, but like, how do we actually make it work? And I think that's where the MBA has really helped. And then also clinically, I think there's also leadership courses that we take. And so, you know, as we all know, the more senior you become in medicine, like you're inevitably a leader within that like team, right? Mm-hmm. Whether I've not yet like quite been a chief, though we take chief call as a PGY 3. Mm-hmm. And it's like, how do you delegate? How do you understand how to triage something? How do you ensure that you are calm in like difficult situations, which we know happens in surgery almost on a daily basis. And so these frameworks for leadership as well, I think are really important and has informed a lot of how I function as a person even clinically.
And has this MBA helped you manage your personal finances as well?
You don't get as much personal finances, but it did make me realize that I need to manage them. So I now push everybody else to make sure that they're saving for their retirement, even at an early age.
And since you said your program is academic, so and even within your research year, you get to decide in which institute you will be doing your research, whether it is your home institution and you need to go somewhere else for your research, or how do you decide it, especially in academic programs?
Yeah. So some programs might have a stipulation on where you do the research if there's funding involved, but in general, they want you to do the thing that is interesting to you, because ultimately this is going to impact your career. So especially at my program, like our leadership is very interested in like making sure that this contributes either to like our fellowship application or like what kind of like practice we want to have one day. Many people stay in Boston at any of the Boston hospital institutions because we have so many hospitals there, and I understand that. And also, this is a time in surgery where many people actually start families and like have loved ones in the area, so they don't really want to move even to another city. But many of us also know that like if we are not finding the mentorship that we really want at our institution or one of the Boston institutions, there's at least like 2 people every class that will go outside of the city to look for that mentorship. And our program definitely supports it. They just want to make sure that like, because some of those outside programs can be a bit of an unknown, they want to make sure that that outside program will still support us really well.
Okay.
That we don't end up in like, you know, a toxic relationship with a mentor that's like either not overseeing what we're doing or, you know, treating us poorly, things like that. They just want to make sure, because they, you know, internally they know, you know, which are the surgeons that are doing a lot of research, grants. They have all of that data. And when you go to an outside institution, you have less of that. A lot of the onus is on the resident, though, to figure out what they want and then who they want to work with. And that can be a little bit tricky when you're clinical and trying to survive residency. But I knew that this was what I wanted to do. And so I started quite early talking to a lot of different surgeons, like who are they mentoring? What are the projects that they're involved in? What opportunities do their mentees have access to? And because I knew I wanted funding to really like live and understand the community that I was working with, Fogarty ended up being kind of like a very aligned decision for me of like getting the funding to be able to be in one place for the whole year. And I'm very happy with, you know, how it went about, but it did take more work on my part because I went outside of my, you know, institution. And so having to talk to other people. But I think ultimately me putting in that work for myself meant that I found projects and people that I knew I would be a lot more committed to, you know, because I was like, this is what I care about deeply. And so this is aligned with what I want and meets my learning goals as well.
Yeah, I appreciate the extra mile you have went in identifying all those research positions and eventually coming in Nepal. So let's go back into your residency days. How does your normal week look like?
It kind of changes depending on which service you're on. So for residency, every residency has a kind of different way of doing it. But generally we have different rotations that can be anywhere from like 4 to 8 weeks, depending on which year of your program you're in. And so depending on if that specialty has more like elective cases or emergency cases, that's kind of what ends up deciding how the call schedule looks.
Okay.
Generally, most residents, I would say, they'll work 6 days a week, usually about 12 hours a day. in some specialties that are more like elective, day surgery based, like endocrine surgery, breast surgery, tends to be, you're usually done by like 4 or 5. You might have more clinic time, but then in other, when you're covering like the acute care surgery service or the trauma service, you don't have you don't have trauma clinic really, right? So you might only have like clinic for 2 hours a week, but then the week is entirely defined by what trauma comes in that week. And so the operative level is also dependent on just kind of what comes in. And so things vary. But I would say generally people work at least 6 days a week or so. And then that also varies because sometimes you might work 2 weeks in a row and then get 2 days off. A lot of our work hours are stipulated by the ACGME, which is kind of the accreditation body for residency. And they have restrictions on work hours. So it's like 80 hours a week, but averaged over 4 weeks. So they understand that sometimes in a month, you might have 1 week where things are really crazy and busy and you work 100 hours. But as long as you have another week where it's lighter, that balance allows flexibility in the scheduling.
And even within your week, what is the distribution between actual learning that happens with the patient or bedside learning, or that happens in the operating room, or there are some classes like in medical school, or how is it?
So I'll work backwards on that one. For our program, we have mandatory didactics every Wednesday morning, and that starts with, we have our morbidity and mortality conference first. And every program does this, like surgeons come, this is kind of like an all levels of department program, but I think it's a very valuable piece of learning. And then we have grand rounds right after that, which is also open to the entire department, but is a learning thing. And then we have resident specific didactics for about an hour and a half after that. And there's like a different topic every week that's covered. And then some weeks you'll have PGY level specific additional didactics. So for example, during my PGY 3 year, we have a cadaveric anatomy course that we do for 10 weeks. And so then we have like an additional like 1.5 to 2 hours of didactic time every Wednesday for about a 10-week stretch. Versus like, the interns, when they come in the first 6 weeks of their intern year, they have additional like suturing practice at the beginning that is added on. So that varies throughout the year for didactic time. And then learning, I think, varies over the PGY year. So I think as an intern, your learning can be very like practical. It's like learning to deal with like first line issues, a lot of things, but then it's also a lot of like paperwork. You're doing all the documentation, the discharge paperwork, and things like that. You're making sure that patients are set up for whatever services that they need. So sometimes I feel like that can feel like it's more busy work than it is learning. On the flip side, it's also, I think, learning about the system that the patient actually goes through. So you have less operative learning, I think, during that time, and less operative learning about operative management too, because you're not the one making the decisions and you're not the one that's expected to come up with complicated plans. As you get more senior, I think you get more and more operative learning in the operating room as you get more autonomy. But that learning also changes from just learning the technical skills of how to do something to how do you manage a complication?
Got it.
And so I don't know if I can give you like a percentage of that over the course of time. How much is learning, how much is how much is just like busy work. I think that also changes program to program. And some people could say like all of it is learning. I disagree with that statement though, because I definitely think sometimes hospitals can take advantage of the fact that you have residents to be able to do everything that's around. But for the sake of surviving residency, I do try and take everything as a learning experience.
And how about the non-technical skills? Like there are a lot of things like you need to be a good leader. You need to be a good decision maker. You need to have that resilience to become a surgeon. So when do you learn this? Because I'm not a surgeon yet. And when I think about all these skills at one go, I feel like it's overwhelming to think about all these skills at one time. You have to be trained technically as well, and you have to have all these skills. So in your individual experience, how was your journey like?
I think non-technical skills are so important. And like, I go back to my MBA, honestly, when I think about these things about like organizational culture. The big thing about non-technical skills is you can start learning them right now, because it is how an individual approaches the world, their work, stressful situations, and you don't need to be a surgeon to figure that out, right? It's like when you work in a group project and you have something stressful happen, how do you handle it? When you make a mistake, how do you handle it? When something difficult happens to you or to your family, how do you learn to balance that and work or create boundaries? Or when a junior to you, because even now there are people who are junior to you, come to you and say, I'm having a difficult time with this, or I think I made a mistake. How do you respond to those people? So anytime in medicine, actually, we are always learning these non-technical skills and how we relate to each other. And being mindful of that is really important. Like, you have an exam coming up that's going to be really hard. You're really stressed out. And then some issue comes up with your research team, or some issue comes up with like a junior you're working with. How do you handle that when you're under pressure? Because it's that same skill set, that same baseline emotional awareness about it that you will carry into surgical residency, right? It's just that it'll be a different situation. But who you train yourself to be will still show up in that moment. And so I think right now what you can do is like do a lot of reading around like understanding emotional intelligence and like team dynamics and leadership, and start cultivating that in your everyday. Because when you start making those habits just a part of who you are, when those hard situations hit in surgery, when it is life or death, it's what you will have practiced that shows through. Right? You don't want that first situation where you realize you need to be a really good team leader to be when someone's life is on the line. You want all those practice sessions for like when their research got messed up or like that paper got messed up. You want you want to make those mistakes under safe conditions. So start thinking about it now. When you get to the surgical field, though, a lot of it comes, I think a lot of people absorb these behaviors subconsciously. They see how their seniors act. And if that is the status quo, when they become that senior, that is how they react. And in an environment where you're so stressed out all the time, sometimes people don't have enough time to think about, was that actually the right behavior? And so we talk, I think, in surgery, especially as like surgical culture change is happening, right, about toxic behaviors and surgeons yelling and throwing things and all of that. How do we change that? Because like at some point somebody has to say like, I know I've seen people act like this, but it's actually not the right thing to do. And I'm going to be self-aware enough to not continue to, exhibit that behavior. So as a senior, when you are a senior, it's also then about demonstrating behaviors that your juniors are going to observe. So it's a total spectrum from like day one of just being able to handle small little mistakes to like one day being able to be responsible for someone's like life, and taking that seriously. And it's a constant practice. So think about it every day. I think a lot of what underlies non-technical skills, though, is humility. And in surgery especially, it is always being humble, because the human body is a masterpiece, right? Like I think we can all agree to that. Which means like we are going to make mistakes, because as one human being, you can never fully understand everything that happens or impact everything that happens. And so there are going to be terribly difficult moments in all our careers that happen maybe for like, absolutely no reason, or maybe because of us. And we have to be able to handle those moments with humility, to understand the human factor behind that. And then be able to set a good example to our juniors and to our seniors, to everyone on our team when those things happen. And so you can practice those skills at any time.
Yeah, I feel humility is the most fundamental thing, not just surgeon, but every clinicians must have.
Yes.
But that brings me to my next question, because as surgeons, even though you are humble, at the same time, you need to be confident or self-aware of your skills. So you can't just admit that, oh, this may be a too complex case for me, I will not do it. Because if you make it as a way to avoid, if you make it as, if you go in that direction, you may never end up learning. Even it may be not just surgery, but any skills. Like even if I want to do IV cannulation, at the back of my mind, I may feel like I'm not confident enough. It's already been 3 or 6 months. I haven't practiced it. But at the same time, you need to have that self-awareness that I have the basics, like how I should be opening it. So what is the trade-off between this humility and the confidence?
I don't think there is a trade-off necessarily. I think what it is being able to hold two truths at the same time. It's being able to be humble and also recognizing that you are the expert and you have to take ownership of that. And I think you'll find that surgeons can be very serious. Like all of this ends up being very serious, right? People practice like repetitively. And so a lot of that I think comes actually back to being honest with yourself. Because if you know you've done the studying, if you know you've done, that Malcolm Gladwell talks about this 10,000 hours of work that you've probably heard about. If you know you've done that, if you've done the repetitions in the classroom, in the sim lab, or whatever that is, right? If you've paid attention to as many cases as you can go to, you've done your best in training yourself to become the best version of yourself as a surgeon. At the same time, if you're honest with yourself and you realize, like, did I go to every case that I could have gone to? Did I ask all the questions that I should have asked? Did I practice in the moments that I wasn't doing anything? You have to be honest with yourself on whether or not that skill is something that you can accomplish and carry out. Because once again, it is somebody's life on the line. And so I think that humility has to be honest, because sometimes that honest humility actually does tell you you are ready. And that you are the person that is there to do that. And of course, that intersects with so many different societal, cultural values as well. So I'm not saying that exists in a silo. But part of, I think, what systemically builds this is psychological safety.
True.
And that is like, I really think that a surgeon cannot become a great surgeon in their own vacuum. That person is always impacted by the people around them, whether that is their senior surgical mentors or the nursing staff, their administration, their peers. All of those people contribute to making an excellent surgeon. It never happens on your own because you always learn from other people, whether it's by how they react to you, how they encourage you, how they discipline you, whatever that is, you always react to other people. And like, I think that historically, surgery has been kind of like very cutthroat and toxic in terms of like disciplining people for making mistakes. But I think ultimately that the best surgeons, the safest surgeons, where that intersection happens, that is built through a culture of psychological safety, which means that people find the safe times to make mistakes.
Okay.
And that when they make a mistake, somebody corrects them in a practical way. Like they actually help them fix that issue, and that they don't just yell at them or they don't just ignore it, because then that person will never learn from that lesson. And the whole point of making mistakes as a trainee is so that you can learn from it. Otherwise, what is the point of having made that mistake? The only person I think it harms is the patient. So you need to have someone there being like, oh, no, actually, if you do this other way, or if you fix that one thing that you did, then you'll have it better off next time. And we have to be able to be open to receive that feedback, but we also have to receive that feedback from people we trust. Otherwise, we just will not receive it, right? If you hear feedback from someone that you're like, I don't really respect them, like it's psychologically, it's going to hit differently than feedback from someone that you trust to give you critical feedback. And so, like, I feel very lucky in my program. I think like people are generally very nice and caring and have each other's back. And so that allows us to ask each other questions of like, I don't know what this is. Can you tell me? And not feel shamed for it.
Okay.
Because that is the moment where I think you make dangerous surgeons, when people actually have not been able to fix what they don't know or they're making mistakes on. And when they're not going to ask for help when they need it, they get into a tricky situation. They think they can either handle it or they freeze. They haven't trained, once again, this habit of, I'm in an area where I don't know what to do next, but actually I know 2 operating rooms over, my senior partner is practicing, is operating, or they're just done with the case. I'm going to call them. You ask the circulating nurse, hey, page Dr. So-and-so, I need a second set of eyes. So I think one of the biggest things that my program has taught me, and that they really emphasizes like asking for help when you need it. And I appreciate that because I learn so much more when somebody actually tells me the correct answer as opposed to me just knowing I made a mistake.
Yeah, I echo your idea of asking for help because that is the first thing we even learned while doing the primary survey and ATLS as well. But I would like to ask from my perspective. So I trained out of medical school, and the setting I work right now is a semi-urban setting. So I am the only physician posted there.
Yeah.
Physically, I have that access to my mentors or seniors from college digitally, but when I have to decide then and there, it's me who should be deciding. And if I have other people behind my back, I would definitely ask for the help. But compare to a rural surgeon. So I want to frame this in that perspective. So there is a rural surgeon, he's open to feedback, but there isn't someone who is at that point of time to give that feedback. And they end up learning that skill of, there is something called learned helplessness or something like that. They ask for feedback, they don't get it. They try it more and more time, and it's like, I think there are some rat experiments on this as well, the learned helplessness. So how can someone, like, even for me, if I train and become a surgeon and 5 years from now, I'll be posted in some rural area of Nepal, and I should be the one doing the cases. And at that point of time, how can I self-reflect, or how can that part of digital or distant mentorship be more effective?
Yeah. And ultimately, I think part of this is a system failure, right? Like, it is not the fault of the sole physician or sole surgeon that they are the only person there. They didn't build that. They did not make that choice to be the only person on call there, right? And it can be from like a lack of resources or whatever the reason is. Oftentimes it is a lack of resources. And so I think nowadays, in the age of digital communication and internet, this is where kind of I think like virtual consultancy is really nice. Like, I know so many surgeons who like constantly are sending like case questions on like WhatsApp or like Zoom or whatever that is. And they have these like networks of people that they check in with constantly. One of the really cool initiatives that I have seen happen is cross-country tumor boards, where and oftentimes is like a high income or a high resource setting with a low resource setting is they'll do tumor board together to be able to plan out how a cancer case should move forward. Should it be operated on? Does it need chemo or radiotherapy or something like that first? And that's like a learning lesson for everybody, because then also the high income country surgeons learning about like, how do you do this in a lower resource environment, right? Or like, if they don't have laparoscopic or robotic surgery available, what are the open techniques to be able to address this? Or is there a completely different thing that people are doing in a resource strapped setting? So I think it is then at that point about building in a system that supports that physician who is on the front line, so that they have access to people. I think a few different groups are coming up with like apps for this to help with like rural surgeons in rural settings. And so that there's like a place where you can like post a case or post questions, and hopefully people in real time would be able to respond. I know that is like there's a pilot program of this happening with the program in global surgery and social change. Some of the fellows over there are working on like an app to be able to connect people from around the world so that they can ask clinical questions that come up in their practice, especially if they're rural, and then be able to get feedback in like a timely manner. So I think that is when we have to realize like the system needs to improve. And of course, we appreciate that sole provider there is like open to feedback, is trying their best, but sometimes you don't set people up for success and then you expect success from them. Like, that is an unrealistic expectation, you know? If you're a junior doctor and you're encountering a very complicated issue, how are you supposed to learn something that you haven't experienced before? I think in medicine, oftentimes we have this like odd way of learning where we think that people should already know the thing that they're there to learn. And I see this a lot on like especially when I now teach medical students. They're like, "Oh, I'm so sorry I don't know this thing." I'm like, "How could you know this thing? You've never seen this surgery before." I'm not expecting you to know something you've never seen. Maybe I can expect you to know like the principles of it. Now you can watch a YouTube video before you see a surgery, but I just don't think that we set people up for success when we give them limited resources no training and then expect them to just learn from a textbook and do their best. We really don't set the system up well. So the system needs to change.
Mm-hmm. How can you elaborate on what do you actually mean when you mean system needs to change?
So that could mean more resources, like making sure that more than one person is posted at a place. That can mean setting up maybe like central resources to be able to call consultants at other hospitals who are, maybe they have a virtual call time where they expect that rural surgeons might be calling them. Mm-hmm. Maybe that is improved referral systems, actually, understanding that rural center is not going to be capable of handling certain levels of acuity, right? So something that's coming in. And so that the pre-hospital system, the ambulance doesn't even take them to that rural setting, that it automatically knows to route them to a higher level of care, right? That's how we build a system where it's like, actually, they're just going to drive the extra 15, 20 minutes to that secondary level hospital instead of stopping at the clinic. Because the paramedics or the EMTs or whoever it is that is with that patient, they recognize immediately that they need a higher level of care. So this is the way that systems kind of like build in success, as opposed to sending a patient somewhere where they're not going to have access to care, where, the resources aren't there or the specialist is not there.
Mm-hmm. And so let's move on into surgical training per se. Since you have done a lot of work in surgical education, and more or less you have seen both sides of the surgical training as well, be it in Nepal or in US, definitely. So especially during a residency, how is the assessment back in US? I bring this question because at least in Nepal, the surgical training is 3 years. And rather than competency based at this point of time, it's more of duration based. And you have that big major exam at the end of your 3 years. And after that, you are assessed in terms of, there are some checklists, but whether you have performed this and these cases, when you will be posted in the periphery, these are the skills needed, and whether you have been trained in these skills during a training, and you are not assessed at this point of time in those skills. So why do you think 3 years of training is inadequate in that regard, or why is it 5 years, or if you even take research year, it ends up being double of 3 years in US?
That's a lot of reasons for all of this. I know that the case volume that people are getting in 3 years is actually far higher than what most people would get in 5 years in a US setting. So that, and I know here also that people are usually working a higher level of hours as well. So overall, I haven't done the math on this, and I haven't looked at any research studies that specify this, but I suspect that they're getting the same amount of exposure to surgical care as a US resident, even though that the time frame is technically only 3 years. The other thing though is what are people being exposed to? So in the US, one of the issues that's coming up with surgical training is now we're expected to not just know open techniques, right? But you need to know the open technique, the laparoscopic technique, and then oftentimes you need to know the robotic technique as well. So the sheer amount of information that somebody needs to know to be a competent surgeon just continues to increase. And that is the wonder of surgical research and new technology. But sometimes I feel like the education system around the world, honestly, doesn't quite keep up with the reality of modern medicine.
At least in Nepal.
This is everywhere, this is everywhere. This is something that I know a lot of junior surgeons in the US and a lot of trainees are really scared of. They're like, am I going to be a competent surgeon after 5 years? And so you actually see more and more people going to fellowship now. And a lot of people find fellowship being an extension of training as opposed to specialization. It ends up being a very tricky situation. And so I think part of it is that our medical education systems need to change to figure out, are we creating specialized surgeons and how do they all fit into this larger system? And I think because medicine is very hesitant to change as a system, that's where we start seeing these discrepancies and is this enough training? Are they learning this skill well enough? And people being uncertain of their competency in it. competency-based education is only now kind of rolling out, like functionally rolling out into the U.S. General surgery system. I think it's maybe by 2028, the class of 2028, or people graduating 2028, that they need to have had actually all of this filled out, because it takes place over several years, right? Like somebody who's a chief today, you can't just like implement competency-based review and then it'll, be there for their whole year. It's like the way they have to roll it out is like year by year. But then that means like what platform is it going to happen on? How is it going to inform matriculation to the subsequent year? How do you then compare it with, we have an exam we take every year called ABSITE, which is actually only supposed to be used as a measurement of how somebody is doing in regards to being able to pass their written board exams. But over the last several years has become a proxy measurement for fellowship decisions.
Yeah.
And so actually just in the last year and a half, we used to have a percentile that was given to us to, grade our ABSITE performance. They took that percentile away.
Okay.
Because they were just thinking like, this exam is supposed to be like feedback for the trainee of like how well are they learning. It's not supposed to be what fellowships are deciding who to match. Yeah. So, I think, and I'm sure this is not just in surgery, I'm sure this is in other specialties as well. I think there's like discordance in how we are measuring the level of actual competency for our surgeons and our surgical trainees. We also take oral boards at the end of the after we have to pass our written boards first, which is a multiple choice exam, and then once we pass that, we are qualified to take our oral boards. And at most good programs, most people will pass their oral boards. But it's, I think, an interesting thing because other surgical specialties like orthopedics, they like have to bring in the cases they've done in like their first year of like attending HUD, and then they get evaluated based on like real time, like the real cases that they are doing. And so I always thought like, do we actually need a more practical way to evaluate surgical skill? Because surgical skill is a technical skill. It's not an oratory skill. So I think there's still a lot of work that needs to be done in like developing surgical education practices that actually align with the skills we're trying to develop in people. And now that there's been more research into surgical education, and surgical education is also viewed as its own academic discipline, I think people are trying to fold that in. But it's always hard to change like existing cultural practices in surgery of how people are taught, right? We always think about like see one, do one, teach one. But are we, seeing one done well? Are we seeing one done where the person explains to us all the steps that they're doing, or are they completely like that? The seeing one can be very different, right?
Yeah.
And then we finally get to doing one. Are we doing a simple case first? Are we doing complicated? Like all of this is like, there's more nuance to it than just like what is presented to us. And with surgery being such a highly technical field, we need to adapt to that. One of the really cool things that I was like talking to somebody about in this last year was like simulation and how like athletes and other people who are in these like very technical, like high performance type of fields spend a ton of time like actually simulating what they're doing. And then a much smaller fraction of their time performing that task versus with surgery, it's the opposite. We don't actually spend all that much time in simulation, but then we spend a great deal of time just doing the task. And it's like, is that really how we should be learning? And part of it is difficult when there might not be good simulation for something, right? So it's like, I know sometimes like these laparoscopic trainers are really just not like a one-to-one replica of then doing actual laparoscopic surgery. So how useful is that simulation? But I do think we need more of this like well-researched framework for like how do we build a skill in an individual, like that theory has to come into like surgical education worldwide. This is not limited to like just one setting.
Yeah, I think there has been one recent change. Like up till now it was see one, do one, teach one. Now it's simulate one in addition to that. And I think there has been a lot of talks, at least I heard in TED Talks, like the one like you defined, it's quite variable. Like one can be an easier one for someone, or it may be the most complex case and attending may not be able to do it. So for a trainee, what defines those one? And I think there is one interesting concept like the Kolb's learning cycle. Like there is one experience, then once you have that experience, you reflect on that experience, you try to analyze it, and then you, based on that analysis, next time when you get to do that experience, you change your thing, and then you again go to that experience. How did I do it right or not? And you keep on moving through that cycle. So I think that is an ideal way we should be doing the surgical training as well.
Yeah, some surgeons actually implement people who are attending consultant level surgeons, after every case, they do a team debrief in the operating room before they leave the room. And I kind of love that concept because it's not just the surgeon, right? It's also the circulating nurse, it's anesthesia, it's anyone else that was in the room that can all give feedback. And that also then ties back to the non-technical skills, right? Like what does that mean in building that team? For success? It's not just that the surgeon knows the technical skills of doing it. It's that the scrub tech or the scrub nurse knows exactly which instrument to give the surgeon at the right time. It means that the circulating nurse knows exactly which instrument to open at the right time, how much of that instrument to open at the right time. That anesthesia at the same time might adjust, whatever it is that they need to adjust. If they're expecting a drop in blood pressure, an increase in heart rate, at whatever time that surgery, they all share a mental model of what's going on. And that is what really leads to success, because you can have a surgeon that is highly technically skilled, let's say, right? They know exactly what to do. They know every piece of anatomy. They know every complication that could happen. But what if they get the wrong instrument, or the instrument that they need is not available, or the anesthesiologist is not understanding exactly what's going on with the patient? All of that impacts our surgical plan as well. So you need the whole team to be on board for success. And so I love that idea of debriefing on as a team, and then also as an individual, and getting feedback. One of the new initiatives as part of competency-based evaluations that many hospital programs are doing, including mine, is we have an app called Simple, and we finish a case. Let's say I finished a thyroidectomy, and right after it, I send a in-app request to the attending about that case, and then they fill out a few questions on how I did on that case and give immediate feedback. The window is 72 hours, but the idea is otherwise you only get feedback at the end of your rotation, and 4 weeks later, maybe something really important happened in the first week of your case, no one's going to remember that. So instead, this is a case by case.
Is this research, or actually it is being rolled out?
This has been rolled out.
Okay.
Yeah. I think there's I'm almost certain there's research happening along with it, but they're much further along in the implementation process. And so that is I think it's a really interesting thing, but it's slow to roll out because people are not used to this new habit of I think of it as you just need to incorporate it into okay, patient just got extubated. You're filling out your brief operative note, and calling ahead to the PACU to let them know patient's coming. At the same time, you send your little notification off to your attending to fill in that case. And when they write up their operative report, if they're the one writing up the operative report, then they also fill out the resident evaluation. It needs to be incorporated into habits, right? That happen every time.
Yeah, like you mentioned, even in simulation education, it is said that debriefing is the most important part.
Yes.
So, and the analogy I draw here is once in football, once there is a match, at the end of the match, the coach sits down with the team players.
Yeah.
And he plays the video and he discusses this and this were wrong.
Yeah.
In contrary to that, in football, it's more or less the same team. But in surgery, you have a team that is rotating most of the time. It's lucky if you have the same team, the same nurse or same anesthesia every time. But most of the time, it's a rotating team. So how do you think in situations like this, the debrief can be individualized?
That's a really important point. They've definitely shown that teams that work together more frequently have better outcomes because they all know each other's kind of thought process. I think part of that is in when you build it into this education system, that it is the systems level expectation that no matter whose operating room you're in or which operating room you're in, that just like you do the surgical safety checklist, right? When you're timing out, that you do your post-surgical safety checklist when, patient is waking up, that no matter who in the room is there, that's an expectation, right? And that maybe there's a checklist for that too that helps standardize it, but that everyone buys into this model of care. so that even if it is different people, the plan is the same overall from case to case to case on how you handle these things.
Yeah. So I'm jumping off from this topic.
No.
I'm jumping from one topic to next. So there have been a lot of integrated surgical programs as well. For example, at least to my understanding, for urology, it's 5 years after the medical school. And likewise, it is being rolled out for plastics as well and other different specialties within surgery. So is it well accepted in US, or what was the the pushing factor that caused it to roll out, and how is it evolving? So do you think general surgery will not be obsolete in its term, but if someone wants to go into PIDS, they can have integrated PIDS program in coming years? How do you see this general surgery program and then this integrated program?
Yeah, I think a lot of it is driven by how a surgeon's practice has changed over the years. So before, maybe 30, 40, 50 years ago, people would do general surgery because they would actually practice general surgery in addition to maybe a specialty that they also took on. But now, in the US at least, there's more specialized care. And so people would rather go to a fellowship-trained colorectal surgeon to get their colon out than a non-fellowship-trained colorectal surgeon too, right? So part of it is just that these practices are becoming more and more specialized. And so if you want to be a plastic surgeon, do you really need to learn how to do a cholecystectomy? I don't know. I don't know the answer to that. I think that's a little bit above my pay grade and maybe making the existential decision of that. But I suspect it's no, especially if you're never going to be operating intra-abdominally, right? A lot of plastics don't operate intra-abdominally. So what is the reason to have a general surgery board certified level of understanding of that? I think there is some understanding that needs to be happened of various different systems, of course, but do you need board certified level training in that? And this is where it comes back down to as practices change, do we also think about the practical lived reality of this person and then adjust training to that? Sometimes I think people just think well, I did it this way.
Yeah, I was going to tail on that.
Yeah, I did it this way, so they have to do it this way. But what if there's a better way to do it? And so I think plastics is actually one of the ones in the US where more and more programs are going to integrated. And I think there's been no issue with that. Cardiac and thoracic have also gotten integrated training. Urology, for us in the US, urology, orthopedics, neurosurgery, ENT have all been their own specialty for a very, very long time. Which is interesting with pediatrics, actually, because in many other countries, pediatric surgeons also do urology, all the hypospadias cases and things like that. But for us, it's usually the pediatric urologist. So that changes also depending on which country you're in, how people are practicing. But I think ultimately it comes down to how much of an understanding of something do you need to have for your particular practice? And that varies specialty to specialty.
Do you think there is some economic motivation behind this as well? For example, there has been a surgeon, the surgeons who have already been trained, and apart from their classical thinking, I have been trained in this modality, so you should be trained. So are there any, I would just like to go much deeper on this, are there any economic motives? They may think I went for 5 years of medical school, 2 years research on top of that, and 3 years or 2 years of fellowship. For me, it was 10 years to become an attending. And now the newer generation comes to be an attending in 5 years. So will it saturate my market, or there will be much more competition in that aspect? Do you think, is there any economic thinking behind this as well?
In the US, I actually don't think there's much of that. There is so much need for many of these surgeons that people see much more value in being able to get a functionally trained specialist surgeon done. And actually, the economic issue with this is that people want to shorten training time because in the US, many medical students come out with extreme amounts of debt. And so the push is to shorten training time so that they can earn an attending level salary in order to pay off all their medical school loans. So I'm sure, for I never say like anything is 100% or 0%. So I'm sure there are some people that might feel that way, but by and large, I don't believe that is a big concern in the US in terms of like saturating the market or, having competition. There's generally enough caseload to go around for everything.
So jumping from this topic. So can you tell about your experience on USMLE? And because a lot of our listeners must be having this question in their mind.
Yeah.
I said because I am having that question in my mind. How actually is the USMLE journey to become a general surgery resident in US?
Yeah,
you can elaborate on that.
Yeah, and I can do some of I'll go over kind of the differences as well for international medical graduates. So in the US, how it is, in our 4 years of medical school, generally you have about 1.5 to 2 years of preclinical. So a lot of like lecture-based learning. Though more and more schools are incorporating a lot of clinical work during that time too, because they understand that you never really learn something until you really see it with a patient.
True.
At the end of that time, you take your step 1 exam, which is a lot more basic science related. Back when I took it, which is making me feel old, it was a scored exam. So we tried to get as high a score as you wanted or you needed. Now it's a pass-fail exam. And then you have step 2, which usually you take after the completion of your core clerkship year. So that's when you've completed, usually it's like it's like psychiatry, OBGYN, internal medicine, surgery. What am I missing? There's 2 more. Pediatrics and one more clerkship that I'm forgetting right now, which maybe I'm showing my age. Some people also do neurology during that time. And so then you take step 2, which is a bit more clinical based at the end of that. Previously, and I don't think they're ever going to bring this back, was you had a clinical portion of step 2 where you went and did like patient simulations. But with COVID, they canceled that. And I think generally I don't believe that they're bringing that back. And then step 3 for the typical US grad is usually taken after graduation, like your intern year, within like the first 3 years of like your residency. In terms, you need to take all 3 of those to like get various levels of licensing and then, to be able to take your board exams. Of course, the hope is that you pass all of them. Grading for them, or like the worth of the grade that you get on it, varies kind of specialty to specialty. So before, step 1 was a big predictor of like kind of your competitiveness for residency because it was a score for it. Now it's pass fail. Of course, you can't do that. However, I say it's very important that people pass on their first try, because I do know that residency programs will screen people out who do not pass on their first try. So I think the biggest thing with that is pass the exam, pass it well, without like being worried about it. I think because of the changes in scoring, when people used to put emphasis on step 1 scores, now it's an emphasis on step 2 scores because that's a differentiator for people. So I think competitiveness of that exam has gone up. And usually people only apply with step 1 and step 2 to residency. So those are the scores that matter, along with like your grades, your research, other parts of your application as well. And in the US, and I know this is different here in Nepal, where there's like one exam, it depends entirely on how you do on that exam, what postgraduate posting you do. In the US, they do also take into consideration your personal statement, how much research you've done, or like, other kind of like significant projects that you've been involved in medical school. All of that goes into your residency application. So some people say that you can make up for like poorer scores by demonstrating like, having a second degree or like something else, and like overall being a well-rounded person as well. So they do look for people who I think are like a good fit, more so than just like exam scores. That being said, of course, if you get a really bad score, you fail an exam. It's hard to make up for that no matter how much research you've done. So kind of being a clinically competent physician will always be the number 1 priority. But of course, if you're applying to an academic program and you've never done any research and you have no research interest, they're going to question that. So they want your application to be kind of aligned, that it tells a story that makes sense about who you are and why you're applying to the specialty you're applying to, or the program you're applying to, or, whatever that is. Step 3 and the scoring for that depends on your specialty. So for me, for example, in general surgery, I really just needed to pass the exam. Fellowships don't really take a look at our step 3 scores because we have other testing scores, our ABSITE scores, for example. which although they're not supposed to be used for fellowship selection, that's what they have been traditionally used for, right? So they don't usually look at step 3 scores. And so people usually just take it to pass it to be able to get their full license. I know in other specialties like internal medicine, fellowships do take a look at your step 3 scores. So people do try and do as well as they can on them. I also know for IMGs, there is a bit more of a restriction on the fact that I think people... And don't, this is like a better question to probably ask somebody who was an IMG that like successfully has gone through general surgery residency for the specifics, is people will take step 3 before applying to residency, sometimes for the score, or they have to get it done in the first half of their intern year in order to like keep up either visa or licensing requirements, given the fact that they're an international medical graduate. So there is a bit more of a stipulation around that. It doesn't always mean they have to do well on it. Like the score doesn't always matter, but I do know that they usually have to take it at an earlier date in order to like apply or stay eligible for US residency.
So even from the medical school I graduated, USMLE, many seniors used to do USMLE and even get matched. So, but it would be mostly on internal medicine and other medicine-related specialties. I can count on my fingers who matched on general surgery. And they had the bio, or like you said, they had developed their CV in that holistic way. They had good scores, and even if they didn't have good scores, they had something else that was compensating for that. But if someone is thinking, okay, just let's go a bit before that question. If someone wants to do USMLE general surgery, what should be their expectations? Why should they be doing it? Or I think that is the question they should ask themselves. But if you had to advise, these are the things that is done differently in US, or these are the peculiarities of general surgery training in US, what would they be?
Kind of like, so are you asking about like the difference in general surgery training compared to like what I've seen in Nepal?
Yeah,
like considerations for an applicant?
Yeah, in comparison to Nepal.
Yeah.
Yeah.
So if we, this is a complicated thing. So like, let's take it back a little bit to that first decision of like wanting to leave your home country to go and train somewhere else, I think is a complicated decision, and there's no right or wrong answer there. I absolutely understand that like people hope for economic stability, right? For themselves, for their family. And the reality is right now that the US will provide, like their surgeons are compensated significantly better. I think they're probably the best compensated surgeons in the world, but like definitely in comparison to like what Nepali surgeons are compensated. And I understand the desire to want to, you know, have that. And I hope that one day the systems here change to be able to keep a lot of the amazing talent that you have here in your student body, you know. I would never say that like the US is necessarily a better system to be training in. I think it is a different system to be training in. Clinically, kind of like overview of differences, I would say is in Nepal, you're probably going to get a lot more open surgical training because you have less access to laparoscopic and robotic surgery. So you will become a much better open surgeon, most likely. You'll probably become a much better clinician because you have to be able to diagnose somebody with a lot more of your clinical exam and like physical and like history and physical skills versus in the US, like somebody walks in the emergency room, you can CT scan everybody and their whole body, right? And that is kind of the practice, is like you can just do all of these like labs and imaging to figure things out, versus here when you're thinking about costs for patient, you really have to rely more on what is your physical exam skills, what is your, you know, clinical understanding of this disease process, how it presents, and things like that. So I think the chances of becoming a much better clinician are higher in these situations when you don't just have easy resources to rely on. That being said, in the US, then you'll learn more about, you know, these more minimally invasive ways of operating. You will have a lot more exposure to like the newest technologies and newest treatments, you know, whether it's like cancer care or like medical devices, things like that. So you'll have a different exposure to that, but you will be a weaker open surgeon. Like I have never done an open appendectomy ever.
Yeah.
And
entire 2 years?
Yeah, entire 3 years. Yeah, I've never ever seen one. I haven't even had a patient anyone has considered maybe we should do an open appendectomy. Like it's not a question. Like we do laparoscopic on everybody. And that just is what it, now we do robotic appendectomies on people, like it's like a completely different kind of training ground versus like here, I know like open appendectomy is still like a very commonly done procedure. And I think about like, well, if I get into a complication with a appendectomy, like a patient undergoing appendectomy, I would just do a laparotomy on them, right? Like there's like different thinking, a different set of skills to be thinking about. So there's clinical differences in terms of that. There is also cultural differences in how people practice medicine. I know there is more litigation that is happening in Nepal, but like in the US, a lot of people practice what we call defensive medicine because they get sued for everything.
I had heard of evidence-based medicine, but I've never heard of defensive medicine.
Defensive medicine is like a very common thing that happens in the US. And that's also what increases all of our documentation. So one of the factors for burnout, for example, in the US is actually the amount of paperwork we have to do. Even though it's all actually electronic versus here where a lot of things are still paper records, but like you just kind of write it in the patient's booklet and then you send it with them and that's it, right? So it's a different system here because of resources. And so people are not getting burned out by paperwork. They're getting burned out for different reasons. But in the US, you're getting burned out because you're documenting so much. So there's different pressures that come in with all of this technology that's there. Your average patient, there's still definitely patients that have like low health literacy, I think, across the board, but and there's also still patients who are fearful of medical systems across the board. It's just that I think it presents kind of very differently in both of these cultures. So that's like kind of clinical aspects. Culturally also, I think hierarchy in the US is decreasing within surgery. And so trainees are really expected to be like independent, to think up plans and to like present that. And like, I think a lot of people are congratulated for taking initiative and following through with that initiative and going above and beyond in like research and like other projects versus kind of like what I've heard in Nepal is like there can be a lot more barriers needing approvals from like seniors in order to get like to work on projects and things like that, which can slow people down. And then I think the other big thing to think about is anytime anyone moves to a different country, I've had some experience of this because I've moved across many different countries, is if you have no support system in the US and you want to move there or you want to move anywhere, you're about to do something very difficult. And it will not be the same as having your family with you to help you through that difficult time. And so I feel very lucky. I'm at a program that has a lot of IMGs, both like prelim and categorical, and they're very supportive of their prelim. Like IMGs, nobody is like, treated differently or anything like that. We're a very inclusive program. Yeah, I love it. It's a super diverse program. And, there's like people miss home. They're homesick. Like life is different. Culture is different. The food is different. In Boston, it's cold and it snows. It snowed so much this year. I'm so glad I'm not there this year. And those things impact your mindset, I think, when you are training, when family is 10,000 miles away. And so those are, there's many different things to think about when you think about just like going somewhere else. And you might find that you don't love certain cultural values in the US. Like in the US, it's very individualistic, right? South Asia, much of Asia, Latin America are very like communal cultures. And that like culture shock can be difficult to deal with when you're used to having people who will help take care of you. And then you move to the US and there is nobody. Like you're living by yourself or maybe with a roommate that you don't know, you're paying a ton in rent. You're working all the time. Those are isolating moments. And so you have to consider all of that, I think, before making that decision to go. And then in terms of applying, which I'm assuming would be your next question to all of this, is there. I think there still is like discrimination against like IMGs, and that differs also depending on which country people are coming from. And it differs program to program to program. I think that my program is an exceptionally welcoming program to IMGs and to people in general because that is the culture there. And that's one of the reasons I chose that program or ranked it highly was because I knew people would have my back. It'd be a lovely place. It's already hard. Why make life harder by being around people you don't like, But
Indeed.
A lot of, people coming from other countries, like you're going to have a break between medical school and residency, right? Because people are going to try and do research, rotations, things like that, versus the average American grad is going to go usually straight from medical school to residency. So there's no break in clinical skills training. A lot of people will try and go to the US and try and get like a research fellowship or postdoc position or a master's in something in order to like have exposure. What I've seen a lot of a lot of IMGs do is also do observerships, but those can be tough because you're literally just there watching people do things, and you can't like quite contribute the same way that US fourth year medical student who's on their acting internship can like go and touch the patient and do things to help the team. And if the team doesn't incorporate you into like their workflow, these are difficult situations and how you can prove yourself as like a valuable member of the team. So all of these things don't always like add up. You know, it's a difficult process. It is still hard to match into a categorical position as an IMG. It is not impossible, but it is also program dependent. My program, I'm going to say almost on a yearly basis, will actually take an IMG categorically. But once again, like I think that's like a positive cultural attribute of my program. A lot of what the IMGs will do is they'll get into a preliminary position. So this will be an intern year position for 1 year. And I think that's kind of the best way to prove themselves as like a really excellent resident in the US. And then during that first year intern year, they'll also usually reapply through the match process, either for another intern year position or a PGY2 position. And you can also apply out of the cycle. And so if you prove yourself in that preliminary first year position as like a really good resident, then usually your program director will also like vouch for you, get a good ABSITE score, things like that. And then you can try and either find like a off-cycle PGY2 position, or some people will do a preliminary second year, but you can only do up to preliminary 1 and 2. ACGME deems that like once you're PGY3, you have to be in a categorical position. So then after PGY2, some people you can kind of do like both an upgrade and a lateral move. Either after PGY2, you become a PGY3 somewhere categorically, or some people become a PGY2 somewhere categorically. I think ECFMG is kind of limiting kind of the like becoming an intern all over again and then like repeating that. I know there's some policy changes happening there, but I know that's happened in the past as well. So I know a lot of IMGs that will first like apply into preliminary positions, try and do their best to show that they're an excellent resident through that, and then match into categorical positions after.
And how is the application with fellowship, if you could add on it?
Fellowship application, they do not, as far as I'm aware, they don't really discriminate whether you started as a prelim or a categorical resident. If you're graduating as like a PGY4, or a PGY5, like they view everyone roughly along the same playing field. So if you've gotten there, like fellowship is about how you did in residency. And generally looks at ABSITE scores, which like, it'll be interesting to see how that changes now that there's no like percentile scores you can look at anymore. Research that's been done, if you did any research fellowship in that time, recommendation letters from people in the field, so in that specialty. And generally those are the kind of big things. So recommendation letters, ABSITE scores, and kind of like research or contribution to that field that people are interested in.
And is there any accreditation body for fellowship like there is ACGME for residency?
Yes, I think there's a couple exceptions to the fellowships, and there are non-ACGME accredited fellowships as well, but most of the fellowships that people look at are ACGME accredited fellowships. So they have, I think, their own specialty committees for each specialty.
Because I have heard I have witnessed some Nepalese surgeons, they finish their general surgery training here, and few people go for ACGME. I haven't heard of them, but a lot of them, a sizable number of them go into the non-ACGME accredited fellowship, and they come back because what they wanted was, like you said, the difference in perspective, the difference in the way to approach the disease or pathology and all those things, and they come back. So if there would be some metric to evaluate yourself, or to evaluate the program, like which of the program would be a good fit for you in terms of residency, or should I be going for residency after my medical school, or should I be going for fellowship after my residency?
I think it depends where you want to practice. If you are dead set on wanting to be a surgeon in the US, then you need to train in the US. If you want to practice here, then I think that the best thing to do is train here. And it's not just the US, but there's many different places that will take LMIC surgeons for fellowship to train them with the knowledge that they don't have specialty fellowships in their own country. And I know that happens in like Singapore, Australia, many different places. So I think both pathways are completely legitimate. It just depends on where you want to practice. You know, that's like an internal question of like what you want to do. But I think both pathways are legitimate.
And I have heard of few states that take IMGs who have done their general surgery training in other countries, even to practice general surgery in US. But I think there is some kind of prohibition or limitations to that. So based on your perspective, if you had to reflect on someone who is trained within the system of US, maybe US has its own reasons to do that move. There may be scarcity of surgeons in some rural areas. But on your perspective, if you had to compare these two surgeons who have been trained in totally different perspective and trying to work within this ultimate US setting, so how would you compare those two kinds of surgeons?
I think, one, it depends where the other place is. There are certain settings that are going to be more similar to the US setting than others. And so that is a spectrum, right, of change. I think ultimately it comes down to like, what is the disease burden that is there and what is the skill set that's needed to take care of that disease burden? And that is what we need to look at. I think that we have tons of excellent surgeons all over the world, right, that have trained through many different programs. But if they go to any different setting, there's going to be things they don't know. Like, for example, somebody coming from a paper documentation setting to like an electron. I know it sounds like a thing that like shouldn't be a big deal, but it will drive that person nuts, that change, because they'll be like, how do I order these things? There's certain sign-offs or orders that only the attendings can put in. They have to learn all of that. They're not used to it. It's going to slow them down. It's going to stress them out, right? Or there's also certain cultural differences that can happen in terms of like how people maybe take surgical consent or counsel patients. In some cultures, like people are more paternalistic, and that's just how things have been, versus in the US where patient autonomy is like constantly talked about. And it's like little things, like sometimes even the English that we speak that's accented.
True.
People don't always understand, especially in the US where like, I know the US can be demonstrated to be a very multicultural place, but there's many places in the US where people haven't gone more than 10 miles outside of their hometown, right? And so they never heard a person speak a different type of English.
I have felt that.
And so there's all these difficulties that we don't sometimes anticipate that can happen, that do make it a different experience to come into a new setting and train. And so more so than I think saying that like anyone trained in one setting will be suitable for another setting, I think it's about determining what are the skills needed, what are the skills that person has or does not have, and then how do you make up that difference for it? Because it's going to be hard also for an American surgeon to come here, right? And not be used to the level of I just think about like for us, we have very strict surgical operating room schedules. Like cases start at 7:30. Everyone is scheduled. The patient comes in 2 hours before their scheduled surgery. You know, there's a whole process, versus here it's kind of like you just go as you know, like, okay, there's the OR board and then people are scheduled for today. And then maybe the first person goes in, maybe actually go with the third person on that. It's just like, it's a different scheduling system. And so you have to get used to all of that.
Yeah, we had done one study on it. Like the delayed start is quite common. That ends up canceling a lot of surgery that are scheduled at the end of the day. And you really answered it well. Like you need to identify the skills and identify the difference of the skills and really try to develop on that.
Right. Because I mean, you know, if you go to the US and you don't know how to do a laparoscopic procedure that's now mostly done laparoscopically, how are you, like, who is a patient you're going to be catering to? Because most patients, you know, might want their elective surgery done minimally invasively. And so you have to be able to develop that skill set.
So what are your plans for fellowship?
My existential crisis for this next year I have to figure out is I'm between pediatric surgery and acute care and trauma. I think ultimately I want to work with like kids who are in trauma, but like pediatric surgery fellowship in the US actually doesn't always have a lot of trauma built in. And trauma fellowship in the US doesn't always have a lot of pediatrics built in. But there are people like my like current Fogarty mentor actually who ended up working in jobs where they deal with a lot of pediatric trauma. So I have to figure out which is the best way for that as well. Pediatric surgery jobs are much harder to get though. It's a much smaller community, so the job market is different versus acute care surgery and trauma jobs are a lot more common because most hospitals want to employ somebody like that. So I'm also trying to figure out, job practicality wise, like which one do I want to do? Thankfully, both of those fields in the US have a lot of global health work. And so I think that like my academic work will kind of nicely translate into either one. But next year, my second year of research, I'm going to be at Seattle Children's Hospital doing a pediatric surgery fellowship over there. And we take like weekly call as well as part of it. So I think that will help me determine.
Back to clinicals.
Yeah, a little bit of clinical work will help me determine, do I want to really just focus on pediatric surgery or do I want to do like acute care and trauma surgery? So TBD.
And for residency, like you said, during your medical school, you were already determined that you want to do general surgery, although you had kept some heart for OBGYN, like you said. You just, like, at this point of time, I think even for me, when I have to choose a specialty, like you said, not at an MBA level, I do the calculation of the market as well. So whether there is need of the specialty or not, how many surgeons are already trained on it. So during residency, did you do it? Was it a calculated move in terms of this market economics, or you liked it because you loved the human anatomy and all those things? Was it just clinical decision, or there were a lot of these factors as well?
To think about fellowship or to think about residency? When you had to
think about residency.
For residency, I think I had such a strong pull towards surgery that like I didn't think about anything else. I was just like, this is the coolest thing to do ever. And part of that was that I'd had that exposure to surgery before medical school. I think that drove a lot of what I wanted to do. I will say, that's not the same case for everyone. I definitely know people who do end up thinking about how long is your training going to be before they get like a proper attending salary. And that factors in because they might have family obligations that they need to like, attend to. And so they can't afford to like be on a resident salary for 7 to 9 years of training to become this like super specialist. Either, like a interventional cardiologist is also like 9 years of training versus, pediatric surgeon. But then becoming like a primary medicine, a primary health doc, right, is 3 years in internal medicine residency, and then you would become an attending after 3 years and have a substantial salary. So some people do take that into consideration, and I think that kind of actually comes down more to like economic inequities between students coming from different backgrounds. And so part of that I actually think is like we really need to reduce in the US the medical student level of debt, because that ends up impacting some people's decision making. I was fortunate enough, and I consider it privilege, that like I didn't have to think about that too much. And I loved surgery. So for me, it was like the obvious choice. Some people I know definitely clinically are confused though, and they don't end up deciding what they want to do until like July of their 4th year of medical school. So like 2 months before residency applications are due, because they're just uncertain. And I also even know people that applied to 2 different specialties and let the match decide what they were going to do. So everyone kind of comes in with a different story.
Yeah, I think it's totally individual story you have behind it.
Yeah.
So we have come almost to the end of our talk. I really wanted to continue on and on. But as a closing remark, so if you had some advice. So first, let's start with the reflections.
Yeah.
The expectations you had before coming to Nepal in terms of your fellowship, in terms of the care that someone from high-income country anticipates in LMIC, especially in surgical care delivery. What difference did you find between your expectation and the reality here?
I think that because I'd done a lot of this work before, like I didn't have too much of a gap in what I was expecting. I think, though, seeing something in person always has an emotional effect on you that like a textbook can never quite truly recreate. And for me, specifically working with burn surgery patients, like the burn surgery patients are so poor. And hearing their stories, their concerns, you know, their worry, like that's like a very like lived real experience that like I anticipated that I would be facing, but when you like really go through it and like see the structural issues with fire safety in the rural areas, you know, I don't think anything ever prepares you for that heartache of seeing that. And so that's something that I think also though drives me to want to do more and to improve the work that I can, that can contribute towards improving care for people and being committed to this community overall. But yeah, I think for me, because I've done a lot of work in other settings and I'd had that background, I didn't have too much of like a expectation gap.
Yeah. Even we did one research regarding what is the pre-hospital practice in burn patients. It was done in Kirtipur Hospital. So a lot of personal anecdotes and you go there for research, but at the end of the day, you come being emotional more than,
Yeah, because I mean, like as a doctor, it's like you're thinking about the patient first, right? Like that's what I think most people think about. They're like, I want to help this person.
Yeah.
And that's it.
And if you had some advice to two specific group of audience, one would be medical student or a recent medical graduate like me who are considering to pursue general surgery, whether it may be in any part of the world. And next to surgical trainees who are trying to decide on the specialty they want to choose in. Likewise, in any part of the world, what would it be?
I think for people who are deciding on pursuing surgery is to know that it is a serious decision and it will test you mentally and physically. And with that though, if you really take on the training and you take it seriously, it is just the most amazing thing in the world to be able to like fix someone and do your best for them and to save their life. There's just like nothing else like it. Like I just don't find anything else like operating at the end of the day. But that cannot be taken lightly. It comes with a lot of responsibility. And so you have to be ready to take that responsibility seriously, I think, if you want to go to surgery. And become someone who will improve the field for the better. Like, do not fall into like the traditional toxic ways of surgery. Like we as the younger generation have the opportunity to change this field for the better, which will only ever improve it for our patients. And we should take ownership of that if this is the field that we're stepping into. Whatever that means, whether that's like you want to become the person that cures cancer or the person that like finances all of the surgery or like, you know, whatever that is to you, whatever about surgery matters, like take ownership of it and try and improve it for everybody moving forward and be the best person that you can be in that field. In terms of people thinking towards fellowship, I think that I don't think there's a right answer between trying to figure out the balance of what you love clinically and also what you can get a job in. Like something, I think it's age-old advice to tell people, oh, just do what you love and like, you know, you'll figure it out. Because the reality like is that, you know, people have families to take care of. They have other responsibilities in their life. And it's like, if they spend their entire life figuring out something very niche and they can never get a job in it, or, you know, they pursue a specialty where there's just not a lot of case volume, that's difficult, you know, like you're going to say you did all this training and then you couldn't get a job. Or I think the other thing that comes with fellowship that people think about also is like the lifestyle. Like some specialties are just more work intensive than others. And it's not wrong to factor lifestyle in. Like until we get to the point where like our surgical systems have changed and we're all taking care of each other and, you know, doctors have normal work hours, like it's going to be different for somebody who's doing breast surgery versus somebody who's doing transplant surgery, right? Those are different lifestyles. And so it's okay to want what's best for your family too in all of this, because they're the ones that are going to be supporting you through it. And there's no wrong answers in figuring out the surgical specialty that's best for you, both in terms of your interest and in terms of your lifestyle?
Yeah. Woo. So a lot of learning reflections, and I would say a lot of words of wisdom in the discussion we had. Because I personally, even when I ask to people of specialty, like you mentioned, sometimes it can be too intimidating to ask about what are the economic things you thought behind it. And if I ask someone who is already doing a specialty, I can get a biased answer like cardiothoracic surgeon may say this is the best specialty you can come in on. So yeah, I think the things you mentioned, these are the things I would definitely include in my decision metrics while I will try to make the decision as well. And I think a lot of people who have been searching for these resources out will also find it useful.
And the big thing with that, I would just say, is talk to a lot of people, because you know that all these answers are going to be biased, myself included. Talk to a lot of people, because when we collect all those different stories, you'll hear all the different perspectives. And then whatever it is that is driving you will piece together the story that you need to make your decision. You know? I think, like, for me, when I was talking to people, I remember being like, oh, should I be considering like a community program or a mixed program? And I talked to people in all these different jobs, all these different residency settings. And because I had so many anecdotes to hear from, that gave me a good comprehensive perspective on everything, and allowed me to make the decision that I needed for myself and my learning goals.
Yeah, exactly. You nicely framed it. So at the end of our talk, on behalf of our entire team, I would like to thank you once again for joining us in our podcast and sharing your words of wisdom. And like you mentioned, you must always stay curious, keep exploring with people. And if you like the content we produce, you can stay connected with us. Thank you. Thank you, Anusha, once again.
Oh, you are most welcome. Thanks for having me. It was great talking to you.